This short video is going to review predicted values, also referred to as reference sets. Reference or predicted values are based on data from healthy subjects. Interpretation of a patient's pulmonary function data requires comparison with different reference data. Studies designed to establish normal or reference values are large undertakings. Variables that can affect lung function include age, height, race or ethnic origin, and gender. For example, with age, the lung size gets smaller after maturity. With height, the taller a person is, the larger their lungs. With gender, men have larger lungs and higher flow rates and DLCO values than women. Race and ethnic origin, lung volumes vary with body size and body proportions, and these characteristics are influenced by race and ethnic origins. So if we took a look at the forced vital capacity for 100 Caucasian males who are 40 years old and 68 inches tall, what we would find is that most values would be close to the mean, but some will be higher and some will be lower, okay, the mean being here. Okay. If plotted graphically, the symmetrical distribution around the mean, around this spot, creates the bell-shaped pattern, which we see right here. The width of this distribution is described by its standard deviation, abbreviated as S or SD. So we have 1 SD, 2 SD, 3 SD, or -1, -2, or -3 SD. Approximately 95% of the values in this type of distribution are within the boundaries of plus or minus 2 standard deviations. You are going to see in your book they talk about a z-score, and that's just a statistical term. We're not going to go that deep into it. But if you like statistics, be sure you read up on that. So on the day of the test, you want to identify the age of the patient on that day. You want to measure their height using an accurate device, without shoes and with the feet standing erect with feet together. If you're measuring the arm span, it can be used if a patient cannot stand or has a spinal deformity. And notice in the picture, when you do your arm span, it's from middle finger to middle finger, and the arms should be straight across. If you're measuring their weight, it should be measured with the patient wearing indoor clothes only. And you should always ask the patient to identify their own race or ethnic origin rather than you assuming by your observation. So when we consider all this, then how do we determine what is abnormal? So what they have found is using the 95% confidence level, CL, method is the statistically most sound method to identify what is normal. So you see in our graph here, we have the bell-shaped curve that we were talking about. The mean is right in the middle. And so the 95% confidence interval is identified here, with the upper confidence limit being 2.5% of overall and the lower confidence limit being 2.5 of the lowest. So 2.5 plus 2.5 equals 5%. So of the entire measurement group, the upper 2.5% and the lower 2.5% are the outer limits of what's considered normal. So those are abnormal. So if we use the 95% confidence level to determine the lower limit of normal, that is considered to be a statistically sound method for identifying abnormal results. So when you measure someone's pulmonary function test, if they score in this range of all the samples taken, okay, if they score in less than this 95% confidence interval, then they are on the lower limit of normal, and so they are considered to be abnormal. I hope that makes sense. It gets a little confusing if you talk about it over and over. Another method is the 80% method. Now, this is used frequently just because it's so simple. It's not statistically sound. To do this, to calculate the lower limit of normal, multiply the predicted value by 0.8. So this is kind of what we use when we use the GOLD initiative. With the FEV1, we use the 80% of predicted. Okay, that's the 80% method. And again, it's just the easiest method to use, so that's why it's used frequently. But again, it's not the most statistically sound way to go about it. So recommendations. For spirometry, the 2005 ATS and ERS guideline recommend using the National Health and Nutrition Examination Survey reference equation. And this should be used for patients aged 8 to 80 with 3 race and ethnic groups. Caucasian, African American, and Mexican American are all included. So when you are looking to see if someone has abnormal results, this is what they recommend you use as the standard or the normal. Now for lung volumes, there's really no recommendations from the 2005 ATS and ERS task force on the standardization of lung function testing for lung volume references. However, some possible choices include these different studies here. Okay, but again, there is no specific recommendations from the ATS or ERS. As for the DLCO, again, there's no recommendations from the ATS or ERS task force, but these are some good choices to consider. As for interpretation, when you go to interpret the data, or when the physician goes to interpret the data, here are some standard guidelines to follow. First of all, you want to review the quality data and any comments documented by the testing staff. Any data that does not meet the ATS-ERS recommendations for acceptability and repeatability, or which include technologist comments related to poor effort, the data should be conducted with caution, or your interpretation of the data should be conducted with caution. Data that is repeatable but still usable should be noted by the interpreter in the comments. Reviewing the flow volume and volume time curves can also help the interpreter in assessing quality. For example, identifying a slow start or the back extrapolation error, a cough in the first second, a sharp peak in flow, or end of test criteria. These are all items to look for to assess for quality data. The flow volume curve can help define obstructive and restrictive patterns, aid in the assessment of upper airway obstruction, identify normal variance or other abnormalities that may not affect the numbers but be relevant to the patient's condition. And then any spirometry data without the presence of the flow volume curve graph in particular are just numbers and subject to question. So basically what this is saying is if you have spirometry data, you really need the flow volume curve in order to interpret the data correctly. Okay, going on to interpretation. This is just that critical thinking tree or decision tree for interpreting, and we had a similar copy of this back in our first week there, but the very first thing you're going to do, or the physician would do, is assess the test quality and review the graphs, and then based on this they can go through this decision tree and identify if it's a normal PFT, if there's possibly a pulmonary vascular disorder or an interstitial lung disease, if there's neuromuscular disease, obesity or chest wall deformity, interstitial lung disease, asthma or chronic bronchitis, or emphysema. So this tree kind of helps break that down. And then here is just an example of data and the predicted values that you can use to quantify the severity of obstructions or whatnot. For example, if the FEV1 is greater than 70% of the predicted, then it's a mild obstruction and so forth. So these are just kind of good references for you.